players, 38 players per year will get diagnosed with a concussion. So that means that for every one NHL player that gets this injury, about 5,500 Canadian women get the same injury as a result of intimate partner violence. And yet a lot of the research that is done on brain injury and concussion is done in the context of sport-related concussion. So there's really not very much at all done on the intersection of brain injury and intimate partner violence.
So in intimate partner violence, there are a variety of mechanisms by which a brain injury can occur. This list captures some of them that are pretty typical, and anyone who's attending who has worked specifically in the gender-based violence sector will be familiar with these. Being punched or hit in the head with an object or a fist, pushed downstairs, thrown out of a moving vehicle. And as Paul was referencing earlier when he spoke about the definition of brain injury, strangulation, which happens in nearly half of survivors of intimate partner violence. And strangulation is really worth taking a moment to focus on because it is such a big red flag for future mortality. It can cause brain injury because of cutting off that oxygen and blood flow. It can cause death within minutes of it occurring. And we know that women who are strangled are as much as 1,000 times more likely to be murdered in a subsequent incident with their partner. So it's a really important piece that doesn't receive the attention that it actually deserves. So I wanted to take a second to talk about what to look for. Someone who's been strangled may have a raspy voice. They may report trouble swallowing or breathing, ringing in the ears. They may have red spots in their eyes or on their skin. That's called petechiae. And those of you in the medical field, I'm sure, are very familiar with this. Scratches or bruising on the neck, often because they've been trying to remove their partner's hands or a ligature while they're being strangled. Loss of memory is very common. In extreme cases, loss of consciousness and urination, defecation can occur. But sometimes there are no visible signs or symptoms, but there can be extreme internal injuries like dissection of the carotid artery that can cause stroke and death in months after the incident has occurred. So it's really critical for those working both in the policing and healthcare sectors to be looking for these signs and symptoms and asking the right questions, even if the signs and symptoms aren't there, because we know that women can, as I mentioned, suffer a stroke up to a year after a strangulation incident, and nobody might even think to connect it to a previous incident of intimate partner violence because they haven't been looking for the right things. This one is just showing you some of the things to look for in a nice visual. So brain injury really is often an invisible injury. And these are some of the symptoms that are pretty common for someone who's had a brain injury to experience, and they will often report these things. Someone who has experienced a brain injury is going to display these things. Maybe they seem like they're not listening or they're easily distracted. They might have trouble learning things or following instructions, memory issues, forgetting appointments and chores. Certainly in the context of a women's shelter, all these behaviors can seem to be caused by other things if you're not looking for brain injury. So a woman might seem difficult or oppositional. Maybe you think she's got some other issues that are causing her to be angry or having trouble with self-regulation. But if you look through that lens of a potential brain injury, it kind of all starts to make sense. So this is why it's really important to consider brain injury when we are working with women who may have experienced violence.
So about 5 or 6 years ago, we started the SOAR project. That stands for Supporting Survivors of Abuse and Brain Injury Through Research. So it's a community engaged, multidisciplinary research initiative, collaboration between UBC Okanagan and the Kelowna Women's Shelter. And we started data collection in 2017. There's basically 3 main goals. The first we've called Explore, which is to characterize the incidence and effects of brain injury and intimate partner violence using lab-based assessments. The second phase is called Educate, which is really about using the knowledge and evidence that we generate in the lab to inform education for frontline staff and others who may be providing support for survivors. And then a third phase that we're just starting, we're calling Empower, which is to create better awareness and actual support services for survivors that are, again, informed by the fact that brain injury is likely part of their experience. So the first phase, the Explore phase, like I said, we're really interested in characterizing different aspects of brain function that may have been altered by the fact that brain injury has occurred in this context. And so the first thing we do is a series of assessments looking at psychosocial and psychopathological impairments that tend to come along with intimate partner violence. So we do kind of standardized clinical questionnaires for post-traumatic stress disorder, anxiety, depression, history of trauma and abuse, resiliency and quality of life, any substance use issues. And then we use a specialized questionnaire that was developed by Eve Valera from Harvard University called the Brain Injury Severity Assessment Tool. So the BISA, as we call it, is basically a series of questions related to incidents of IPV with a partner that result in brain injury-like signs or symptoms. So, for example, one of the questions is, after anything your partner did to you, did you see stars afterward, or did you feel dizzy, or did you have difficulty concentrating? And then there are follow-up questions if they answer yes to any of these about how frequently it happened, when was the first time it happened, when was the last time, how long did the symptoms last. There's a couple of questions that are specific to the severity. Particularly, they'll probe about loss of consciousness or post-traumatic amnesia. And so you end up with an overall score ranging between 0 and 8. So 0 is for people who have experienced intimate partner violence. And if it was physical IPV, it was directed at some other part of their body, so their torso or their limbs, for example. Or it was potentially emotional or psychological or other forms of intimate partner violence. So the bottom line is that the head was not targeted directly with any of the violence. In the other extreme, a score of 8 means that it happened quite frequently over the course of potentially months or years. The most recent time may have been, a few weeks ago. And then quite often it may have resulted in post-traumatic amnesia or loss of consciousness. And so the nice thing about this measure is that you end up with kind of a range of scores for different intensities of experiences. And I sometimes like to refer to it as the brain injury load.
One of the things that I really like about the BISA and how it positions the questions is that it's asking about symptoms. So it's not asking, have you ever had a concussion because your partner hit you? Or have you been strangled? It uses questions that will allow people to disclose information that will then let us understand there may have been a brain injury, even if they don't know. We found a lot of women weren't even aware that they might have experienced a brain injury because this was their normal, that their partner would hit them or indulge in strangling behaviors, and they might just not remember parts of it. And they wouldn't have even thought, oh, perhaps I've had a brain injury. So asking about symptoms allows you to elicit information about what may have actually occurred that you might not have got if you said, did you have a concussion or did your partner strangle you? And while I mention that, because you said the word choking earlier, I just also wanted to say that it's important to use language that works for the women with whom you are interacting. So they might often say, well, no, he never strangled me. But then they might say later, well, he chokes me sometimes. Even though choking is a completely different thing, people often refer to it as choking. So it's important to remember in the language you're using when dealing with survivors that you can elicit information by asking symptom questions, and you should also consider words that might be more familiar to them than what that is the technical term.
And so just to complete the kind of background description of how we approached doing this. So we have our BISA score, and we relate that to the different measures of brain function that I'll talk a little bit about here in a second. But then just from a statistical perspective, we want to take into account those other psychopathological measures that I mentioned before, things like PTSD and depression and anxiety, because those can also obviously have a direct impact on brain function and some of the things that we're measuring. So we basically put them all together and try to determine using regression analysis how much brain injury is contributing to what we're measuring versus some of these comorbidities. So just to give you more detail of what we actually do in the lab, one of the main things that we're interested in is brain blood flow. So this is looking basically at cerebrovascular physiology. And one component that we look at more specifically is cerebral autoregulation. So this is just the relationship between systemic blood pressure and cerebral blood velocity. And so in this figure here on the right, I'm showing blood pressure in the blue and cerebral blood velocity in the red on the bottom. And you can see the kind of high frequency spikes. Those are just the beats of the heart in each trace. And then the kind of slower modulation of each waveform is due to a manipulation that we have participants do, which is just to alternately stand and squat. So whenever you squat down, your blood pressure goes up, as does your cerebral blood velocity. And then whenever you stand back up, your blood pressure goes back down, as does your cerebral blood velocity. And then we do some fancy statistics to basically look at the relationship between those two waveforms in terms of their timing and their magnitude. A second thing that we do is to look at neurocognitive function using a device called a kin arm, which is just a bimanual robotic virtual reality sort of device where a participant will be able to interact with a variety of visual objects. And as the task progresses in this particular example, it gets harder and harder to perform it appropriately. So you start to make errors. I've got a short segment of video here that shows this in detail. So this is called an object hit and avoid task. And what the participant is meant to do is hit the vertical rectangles and the circles and avoid all the other objects as they descend from the top of the screen. And so we'll just show the video here. Hopefully you can all see that. And what you can see is that they are more or less accurate, but every once in a while they make a few errors, and we can pick that up with the computer programs that analyze the motion of the hands. So we get measures of basically how fast they're moving and how accurately they're moving. And like I said, as the targets start to descend faster and faster, it gets harder and harder to maintain your accuracy. So just in terms of kind of initial kind of overview of what we're seeing in our participants. So these two figures show kind of the interaction between the brain injury severity assessment score, the BISA score, how it's distributed across all the participants, and then how that intersects with the experience of strangulation. And so you can see that on the left here, BISA score of 0, we had very few participants who had that experience. So remember, that's where if it was physical violence, it was directed to some other part of the body, or it was non-physical violence, so emotional or psychological intimate partner violence. And then as the scores go up, you get more and more participants until you get to the more extreme scores where it starts to drop back down, so fairly normally distributed. But what is shown here in terms of the breakdown is that strangulation tended to be associated with the higher BISA scores. So there was more people experiencing strangulation that appeared on the right-hand side of the graph than on the left-hand side of the graph. And then we broke that down and looked at it statistically and found that the higher the number of strangulation experiences, the higher the BISA score. So it's maybe not that surprising, but strangulation, especially if it's done multiple times over the course of months or years, leads to higher BISA scores, which is reflective of potentially a higher brain injury load. So I mentioned that we hardly had any people who scored 0, and that the kind of mirror image of that is that most of the participants had at least one episode that resulted in IPV-related brain injury. A second thing that's not captured in the graph, but is more of a demographic issue, is that within the population of participants, 20% were Indigenous, whereas in the Okanagan region where we live, Indigenous people make up only 7% of the general population. So it's an overrepresentation of Indigenous women, which is consistent with previous work in intimate partner violence. In terms of the cerebral autoregulation, the main thing we found was that the greater the level of IPV-related brain injury, i.e. the higher the BISA score, the greater the disruption to the cerebral autoregulation. So that relationship between the systemic blood pressure and the cerebral blood velocity. And that's, it was consistent with this idea of increased stiffening of the blood vessels in the brain, which has been linked in other conditions to increase incidence of stroke and dementia over the longer term. So a concern around the cerebrovascular system being affected by IPV-related brain injury, and that potentially leading to longer term effects. With respect to the object hit and avoid task, this is data that was in a paper that was recently published in the Journal of Neurotrauma, showing for one of our variables, average hand speed, that there was a negative correlation with the BISA score after taking into account all of the comorbidities. And so people who scored higher on the BISA tended to move their hands more slowly as they attempted to interact with these objects. So the implication being that the ability of their brain to process that visual information and make that decision about whether to hit the object or not was disrupted as a result of exposure to brain injuries and intimate partner violence. So just to give you kind of a sense of some of the lab-based experiments and the results from them, what we find is that the majority of our participants have experienced at least one IPV-related brain injury. Those that had experienced strangulation tended to have higher BISA scores. One of the things that I didn't show in terms of any data is that, of course, have collected lots of data previously looking at acute sport-related concussion in young athletes, and have been able to assess and compare the number and severity of brain injury-related symptoms. And what we found in our IPV participants is that the number of symptoms and the severity of those symptoms were greater than what we had observed previously in acute sport-related concussion. In terms of the cerebral autoregulation, we get this arterial stiffening effect that's linked to the severity of the IPV-related brain injury, and that's been linked to longer-term neurodegenerative effects. And then in terms of the object hit and avoid tasks, there's this reduced ability to make fast coordinated movements. So kind of the bottom line is that our participants have experienced repeated brain injuries, sometimes over the course of months or years, that result in chronic symptoms and have potential long-term consequences in terms of their brain health.
So the research that we've done to date has confirmed this is happening in most cases of intimate partner violence, and there are long-term implications. So what do we do about it? That's where we get to the educate phase of the SOAR project. The key for me here when we first started doing this work was realizing, running a women's shelter, there was no training on brain injury and intimate partner violence, and there was no understanding of the intersection or what we as frontline professionals could do to recognize brain injury and then support women who'd experienced it. So early on in this project, we surveyed 150 frontline women's shelter workers from across the country and tried to find out what they knew about brain injury and intimate partner violence, what they wanted to know, and how they wanted to learn about it. So one of the results of that research is the concussion awareness training tool module for women's support workers. It's a 30 to 40 minute online course that's available for free in French and English. And it will teach all the basics of what brain injury is, how it intersects with intimate partner violence, how to recognize signs and symptoms, and how to support women who may have experienced it. So highly recommend it, not just because we developed it, but because it's a great course. And as I said, it's free, quick and easy, and share it with all of your colleagues and friends because it's just really good basic information to start the learning and the change in practice around this topic. Some of the other things we've developed so far are some promotional educational type materials. We have a really brief brochure called Moving Ahead. There's one specifically for frontline workers and one for survivors. Certainly the Kelowna Women's Shelter has the survivor's guide and is able to give that to women in their care to give them a starting level education and help them understand that perhaps what they're going through is actually because of a brain injury as opposed to them just not functioning very well. Those are both available to download free on our website, and they too are in French and English, and we'll give you the website address later in the presentation. And then we've also done an adapted version of something called the HELPS tool, which is a really basic brain injury screening tool that can help frontline workers identify if someone may have experienced a head injury. Our research told us that doing an assessment like this would be difficult for frontline workers because they already have so much that they're doing with survivors in those kind of acute phases of them either coming into a shelter or seeking some kind of medical care. So this is a really basic questionnaire, and it can be done in a really informal way just to guide a conversation around brain injury that would help the survivor figure out if it might have been part of her experience, and then start that conversation about how she can get some support. So this too is in French and English and available to download and use if you wish from our website.
The final phase, as we mentioned in the introduction, is called Empower, and we're implementing this in something we call the Community Support Network. So it's a partnership between a community brain injury support agency and our regional healthcare authority, along with Kelowna Women's Shelter and the SOAR team. It's basically a pilot intervention that's multifaceted in nature. So it has exercise component, a mindfulness meditation component, includes some occupational therapy along with cognitive computerized exercises. And so one of the things that we want to try and accomplish with this community support network is to identify some of the gaps and barriers and facilitators and to women seeking support for brain injury after intimate partner violence. And so we're going to undertake that in terms of doing some qualitative work using surveys and focus groups, as well as some patient journey mapping exercises with some healthcare authorities. And then with the intervention itself, we're measuring changes in quality of life, resiliency, and neurocognitive function prior to and after the intervention, in the hopes of being able to show improvements in these factors.
And we're excited because we've got our first cohort of women who are almost done. It's a 6-month intervention, and they are, I think, in month 5 now. So we will be starting those post measurements soon, and really excited to see that we hope there will have been improvements in all these areas for them, and that this intervention will have been worthwhile. So some of the challenges that we face in working within this specific population and with brain injury is that, as mentioned before, brain injury is an invisible injury, but you've got intimate partner violence wrapped up in it, which has so much shame and stigma still attached to it. There's a real lack of awareness or education, both among professionals like yourselves generally, and among women themselves and members of the public, that these two things might intersect and do intersect, and what the repercussions are. Some of the challenges that come up a lot in talking to those who work with women specifically is the fear of repercussions. If a woman is identified as having had a brain injury or diagnosed with a brain injury, will that be weaponized against her in court, or when it comes to custody of or access to her children? We find that women who have experienced a brain injury, of course, have a harder time creating or following through with a safety plan because they're dealing with the cognitive challenges of having had a brain injury. Additionally, her forgetting things and not being her usual self due to the brain injury could then cause her partner to get more upset, and there could be further brain injury. So that's a real problem that we see in working with this population. There's a lack of support, again, because people don't understand how prevalent this is and what needs to be done to support someone who's experienced a brain injury. As a woman who is often also parenting and trying to work, and sometimes is still in a violent relationship, there's a limited ability to rest and recover. It's not like with sports and concussion where you have, all these protocols for rest and recovery and return to play. There's no return to life for women who've experienced brain injury and intimate partner violence. They just got to keep on going. And then, of course, there's financial limitations. The rehabilitation program that we are piloting right now is not cheap, and currently, due in part to the lack of education and awareness, the healthcare system isn't providing integrated, covered supports for women who've experienced brain injury and intimate partner violence. So you've got the treatment costs, but you've also got the time required. And then if someone is participating in a program like we're piloting, which is a number of hours over 6 months, you also have the childcare potential costs. So we have a lot of challenges that we're dealing with and working specifically in this area. Athletes are easier. I think you've said, people see the injury occur often, And there are all these protocols in place. This is a whole different thing when the injury is happening behind closed doors and there's all these other factors. So in terms of ways that you can help every day, there's a lot of great information in the brochures we showed earlier and in the concussion awareness training tool. But here are some things you can just keep in mind if you're working through that brain injury informed lens. Speaking slowly and clearly, taking breaks, certainly when you're working with a woman in a context of doing an intake, whether it's at a women's shelter or in a healthcare setting, taking breaks. Sometimes you've got a lot of forms and a lot of information you have to get, and she might need to take some breaks. So always asking about that. Asking her to repeat information back so that you know she's understood. She might be embarrassed if she's not gathering the information she requires, and she might not ask you to stop or repeat things. So if you can proactively do that, you're empowering her to get the information she needs. There's often a sensitivity to light and to noise. So dimming the lights or going to a slightly darker location or a quiet location is really good. Again, working with her to fill out forms. I know certainly when I was working at Kelowna Women's Shelter, we would often give a woman a bunch of links or a bunch of papers and say, no, go away and fill all these out because you want to apply for housing. So here's 5 different housing applications. And here's the form online that you have to go to apply for social assistance. That's going to be overwhelming for someone dealing with a brain injury, and she might not even be able to accomplish it. So working with her to do that is great. And minimizing screen time is important as well if someone is dealing with the implications of a brain injury. Of course, encouraging rest. It's important to remember as well that these kinds of challenges aren't just in the acute phase of a brain injury where a woman might have experienced, a concussion or a strangulation related brain injury a week or 2 prior. These challenges we're seeing in the research we're doing with the women we're working with can happen for years. So don't think you don't need to consider these things if the incident wasn't recent. And you obviously want to help with prioritizing tasks and appointments. Supplying women with day timers can be really helpful, helping her know how to and practice putting information in her phone and in her calendar on her phone or in multiple locations is really helpful too. And this is something like certainly at a women's shelter, you can keep a collection of earplugs, sunglasses, and hats to give women that will help make them more comfortable. I just want to speak for a few minutes on the importance of trauma-informed practice. When we first started doing this work, it was really about let's teach women's shelter workers about brain injury and intimate partner violence so they can provide better support for women. But the more we did the work, the more we realized that sending women who've experienced intimate partner violence to a brain injury clinician who has no understanding about trauma-informed practice necessarily and no real deep knowledge of the complexity and nuances of intimate partner violence isn't necessarily going to help her because she needs a certain kind of support. So we try to touch on the importance of trauma-informed practice as well as the importance of brain injury-informed practice. So trauma-informed practice really recognizes the effects of trauma. Trauma can cause PTSD, hypervigilance, anxiety, depression, dysregulation, memory loss, and so can brain injury. So you're dealing with a woman who's experienced both trauma and brain injury. She's probably going to have these things at an even greater level. Trauma-informed practice really emphasizes safety, all kinds of safety, because this is a woman who hasn't been safe for a long time. It's really important to create opportunities for personal agency. Women who've been in intimate partner violence have stopped trusting their own judgment, have had their control taken away. So slowly letting them make their own choices and be in control of their destiny is really, really key to trauma-informed practice. It all comes down to meeting women where they are, suspending your own opinions, judgment, and meeting her where she is and working on that level. It's really important, as I mentioned earlier, to consider language and also to consider some of our own preconceptions in dealing with women who've experienced violence. So acknowledging that the violence has occurred and calling it violence is really important. Being really clear that it isn't her fault. She didn't ask for this. She didn't cause this. Honoring resistance is important. We often get asked about, why women don't leave or why they don't leave sooner, as if leaving is a singular occurrence that happens at a point in time. Leaving is a long time process that may culminate with her walking out the door, but the leaving and the resistance occurs over time. An example of this would be, he gets paid every other Friday. He usually goes to the bar with his coworkers. He comes home and he's picking fights, and it usually ends with him being abusive. So every other Friday, she arranges for the kids to go to grandma and grandpa's for a sleepover. That is resistance. That's her finding some power and showing some personal agency. So honoring and celebrating those moments and helping her understand that she's actually thriving and showing some power in those moments is really important. Challenging victim blaming messages. You know, we're still dealing with that in our society. Sometimes law enforcement, often in the judicial system, asking survivors of sexual assault, well, what were you wearing? How much did you have to drink? These are victim blaming messages. We really need to challenge those. And letting her judge her choices, again, that's meeting her where she's at and giving her personal agency. But the most important thing you can do is listen and support. Some things to say. I'm sorry this happened to you. I'm concerned about you. It sounds like you're doing the best you can. These are all really supportive, empowering things you can say to a woman who's survived intimate partner violence. Now, here are some of the don't says. Please wipe all of these from your memory and your vocabulary. Don't should anybody ever. We should all stop shoulding people. But you know, these kinds of statements are very judgmental and solution based. She doesn't need anyone to solve this problem for her. She needs to be empowered to take the steps herself and to be safe herself. So these are really typical things that we will say, always with the best intent, of course, but we have to understand the implications they can have. And the last one is my favorite, which means I hate it the most. These men are pillars of the community. They coach their kids' sports teams. They give to charity. They're charming and funny and the most popular guy at the party often. That means nothing when it comes to what goes on behind closed doors with a partner. So it's really important to never transpose your own experiences with someone in this context. We know that women who receive positive responses tend to recover more quickly, are more likely to cooperate and work with authorities and ask for help, and to report future instances of violence, which is super important. Obviously, women who receive negative response will do the opposite. And the other piece, women who receive negative responses are much more likely to receive some kind of mental health diagnosis, and they're less likely to pursue help-saving supports and services. So it's really critical to consider our language, to meet women where they're at and suspend our own judgment because it isn't about us, and to consider that we can help more by being trauma-informed. Now, there are not tons, but on this website, great resources specifically about brain injury and intimate partner violence. This is a website called the Abi Toolkit, Abused and Brain Injured Toolkit. It was developed by some colleagues in Ontario out of the ABI Research Lab, which is at the University of Toronto. It has resources and information for survivors and also for professionals. There's a lot in here. And if you've got the time and the interest, I would highly recommend diving into this website. It will teach you a lot and leave you even more prepared to support women who've experienced brain injury and intimate partner violence. This book is, this will sound strange to say, it's my favorite book about intimate partner violence. Rachel Louise Snyder is a journalist and researcher out of the United States. And this book is the best book about intimate partner violence that I've ever read. We've both read it and we recommend it to every audience to which we speak, and all of the lab team, they're all required to read it. It's very approachable and well written, and it's incredibly hard hitting, but it explores a lot of the societal context of intimate partner violence and toxic masculinity, and it does address brain injury and strangulation. So highly recommend everybody read that book.
All right, so thank you so much for your attention. I just want to provide some thanks to the funding agencies that have supported the project over the last few years. We've been incredibly fortunate to be able to get some funding and basically to be able to support the trainees and other people that are working on the project with us. We have a number of different graduate students and colleagues, both at UBC Okanagan and at other institutions that have really brought their expertise to bear on some of the questions that we're addressing in this project. And so we're really fortunate to be able to provide that support and build up a great team. And as Karen mentioned earlier, all the information that we just presented is available on our various websites and social media accounts. And if after the question and answer period, you have follow-up questions that you'd like to touch base with us, we're more than happy to have you send us an email, and our email addresses are there at the bottom. So thank you so much for your attention, and we look forward to the discussion.
So we have our first question. It was, how can we get copies of Moving Ahead guides?
Yep, so those are on our website for download. And that's, I want to say it right, it's soarprojectcanada.ca, I think. And one thing I wanted to mention that we hadn't mentioned, we're always worried we're going to run out of time, and then I talk too fast, and we have lots of time. But we've got a group of new student trainees who are just starting with the team, doing their PhDs. And one is a former 25-year career RCMP officer who's now doing a PhD. She has a very strong interest in strangulation and intimate partner violence. And she'll be working for her PhD project on developing some training specifically targeted at frontline police officers. So we're really excited about that and hope that we will be able to have that to release well in the next couple of years.
Yep.
Go ahead, Deborah.
Thank you. It was an incredibly informative and very disturbing presentation. I appreciate all your work and your courage in doing that work. Is there a way, if we're working with someone, a patient, it might even be a colleague or a friend, and we suspect that this is true, that they've had a brain injury and it might have been something quite historical. Other than the testing you have suggested, is there a way of determining that? And one of the things that I find is that with other areas of health, if you can give someone a diagnosis, it's often helpful. And
Yep.
This is a reason why you're having the pain in your stomach or the ringing in your ears. This is why you can't remember things or you're so sensitive to light. And I'm searching for a way of helping people get to that diagnosis who may want to. Is the only way to do that doing the kind of cognitive testing that you've suggested?
Not necessarily, and certainly we've found the same thing in terms of our participants. We don't do a diagnosis with our testing, but all the data is consistent with the idea that they've very likely had one or more brain injuries as a result of this. So, I didn't mention it at the outset, but over the last 20 or 25 years, I've been doing brain injury research in sport-related concussion. And so, the things that the measures that we're using with the participants in this project are many of the same measures that I've used in the past in sport-related concussion, and the results are very consistent. And so, it's a brain injury or multiple brain injuries. The participants I think they feel empowered by knowing that that's probably explaining some of the challenges they're facing. Like I said, it's still not really a diagnosis. I'm a PhD, I'm not a real doctor. And so, having that information in their back pocket when they do engage with the healthcare system, I think is some way to advocate for themselves. And certainly some of the things that we're interested in doing moving forward is to more directly engage ourselves from a research perspective and a practice perspective with healthcare authorities to raise awareness and knowledge of this and kind of leverage the expertise within the healthcare system to be able to more formally diagnose. It's complex though, right? I mean, there's all these other things going on that muddy the water. So all the psychopathological comorbidities that tend to be associated with intimate partner violence can also have an impact on brain function, and in some ways look like a brain injury. And so I think they're interrelated. And so, disentangling that is challenging enough from a research perspective, and it's maybe even more so in terms of providing clinical support and being able to help the person in terms of their care. But I think, yes, it's challenging, it's complex, and we should be doing it.
And the helps tool, that conversation is a great, it's an assessment, but I really do think it's more of a framework for conversation, which can help guide the conversation. And I think it all comes down to asking pointed, open-ended historical type questions to get there, so that you can then say, have you ever considered that this might have occurred? And like Paul said, the reactions of the women has been powerful. They have felt empowered to have a label, like you said, knowing what might have caused this, because these women believe when he tells them, you're stupid. The reason you forgot to pick the kids up from school is because you're a complete idiot and you're a worthless mother. If she can say, well, hold on a minute, I actually have a physiological condition that he caused me, that's incredibly empowering and helps them get back to that place of personal agency. So it's definitely important to do. But as Paul said, the notion of a diagnosis is hard, because we're not yet at a place where you can just take a drop of someone's blood and say, well, yes, you've had a brain injury. So it's definitely complex.
Thank you. I think it's what is helpful is to be able to say to patients or even to family that perhaps suggest to your primary care provider,
Yeah.
that this is something you're wondering about, that you
Yes.
may have had this, and to suggest that. I also wanted to mention that the newest information that I didn't consider before, and I ought to have. We work a lot with seniors, a couple of long-term care homes associated with our work, and that this can cause dementia, or can cause strokes.
Yep.
And my goodness, that might explain a lot around some of the situations I'm thinking of, where I do know personal histories around some of our residents or past residents. And I wish I had have known. I'm so grateful to you for revealing that. Thank you.
Yeah, it's interesting. We've been talking a lot about this and trying to get the healthcare system on board from a funding perspective. We want to be able to get enough evidence to show them that the long-term implications and costs, both in terms of dollars and beds and society, are huge, because women who are living with this through a lifetime and then end up having early onset dementia or Alzheimer's are going to cost the healthcare system a whole lot of money than if we had got them earlier on. But we just haven't been looking for it.
I will say anecdotally, one of our participants who was empowered by the knowledge and information by participating in our study did self-advocate with her family practitioner about, maybe some of the challenges I'm facing is due to brain injuries, and has been quite proactive in terms of seeking out additional care and supports, under the assumption that brain injury is helping to or contributing to some of the challenges. So
she actually took the concussion awareness training tool course and then insisted her physician take the course, because the physician was kind of poo-pooing her notion that she might have experienced a brain injury. So we were kind of excited to hear that. Were there any other questions or comments?
I have another one if no one else has anything just now. And it's around, so my name's Deborah Randall-Wood. I'm the Chief Nursing Officer here at the West Prairie Sound Health Center. I'm interested in your thoughts on recovery, that if there is somebody who we're caring for, who we suspect has had a brain injury, utilizing your tool during our assessments, and they have perhaps early onset dementia or late onset, I'm assuming that if someone is in their 90s in that circumstance, recovery might be much more difficult than somebody who might be in their 20s or 30s. And what are your thoughts on the importance of interventions to try to recover? And I'm assuming like the sooner the better.
Yeah, totally. There are no or very little models of this in the intersection between intimate partner violence and brain injury. Certainly, if you look at brain injury more generally from other injury mechanisms, and sport-related concussion is the one that I know best, there's very well-defined and described protocols. Some initial rest with no or very little physical or cognitive activity, and then starting to reintroduce activities, within a few days. And some recent research showing that physical activity itself is actually a catalyst to faster and more robust recovery. And so that's great in the context of an otherwise healthy young adult who has the support of family and friends and potentially the healthcare system to be able to go through that process. I think it's a lot more challenging in the context of a mom in a family who's living life and is also under the stress of being in an intimate partner violence situation. I think there's more opportunity for it in the context of someone who shows up at a women's shelter or seeks support and has exited the relationship in some way, so has some space to be able to begin the process of recovery. And so I think that's probably the hardest thing would be making sure the person's in a context where they have that space.
Mm-hmm. We know too that it takes on average 7 times leaving an abusive relationship to leave for good. So I know staff in particularly at women's shelters, but in other sectors serving women often struggle with how do we get her there sooner? How do we help her get to that I'm now leaving for good place sooner? And we've had some folks speculate that being able to discuss with women the high risk of them experiencing brain injury in this relationship and what it could mean for them and their kids down the road might be that extra piece of evidence that will be enough for her to go, okay, yeah, I'm not going back. But we haven't talked about it before. So I think it's another tool in the toolbox when you're trying to work with women and help them advocate for themselves and their safety.
Anyone else with questions?
Can I tell you all a cute story? We usually tell this story as part of the presentation, but I was worried we wouldn't have enough time. So I'll tell you the story of how Paul and I and this project came to be, because it's cute. And yes, if you believe in fate, and if you don't, you will after this. So Paul and I met 6.5 years ago. We were both a little less middle-aged then than we are now. And we were both single and online dating. And we both swiped right and went for a great dinner and fell madly in love, because look at him, he's cute and he's super smart. And at the time, Paul was doing sports concussion research and only sports concussion research. And I was running Kelowna Women's Shelter. Probably about 3 months into our relationship, I stumbled upon this editorial piece connecting intimate partner violence and brain injury. And I had my massive light bulb moment, as people do. I forwarded the article to him and basically said, what the are you doing studying football players and soccer players? We need to study women. So Paul applied for a grant. We got a grant and we started this project. And here we are, 6.5 years later, we're still madly in love and doing this work that we're both so passionate about that brings kind of the best of each of us and our professional skills together. And Paul doesn't really do much sports concussion work anymore.
No. I've learned a heck of a lot in doing this work about kind of the context of intimate partner violence. And I always say, this project gets really, really big as soon as you start to consider all the factors that can contribute to why this happens and what the impact is in terms of a person's brain function. And so we've got colleagues from social work and sociology and pathology and all these different disciplines. Ethics is things that we brought into the conversation, and it gets very, very fascinating. I'm lucky to be at a stage in my academic life where I can start to consider all these things, but they're all relevant, which is important, and play a role. So
all that to say, if you're single and you're online dating, don't give up.
That's a very good and a hopeful message, and from someone who's worked with women who have experienced what you're describing for more than 30 years in one capacity or another. We're very grateful that the swiping to the left or the right, I don't know how you do these things, but whatever occurred, that brought you into the sphere of doing this important work. So thank you.
Dr. Casson, were you looking to speak?
I think you're on mute.
Still muted.
Could type your question in the chat.
Are there any other questions? I'm not hearing anything. I'd like to thank you both so very much for presenting today. That was very well done, and I've certainly learned a lot. It sounds like Deborah has as well, as I'm sure everybody on the call has. So thank you so very much.
Looks like Dr. Casson is with us now.
Oh,
hello. I just wanted to say that I really enjoyed the presentation, and I like the way you connected the concussive symptoms that comes from trauma in the sports industry, and now you bring it to domestic violence. And I believe that that's the way medicine evolves. That from one, we just serendipitously connect with the other. And I wish your project good luck. And I have no doubt that it will help enhance medicine in this field. Thank you for this presentation.
Thank you.
Thank you.
One thing we're working on now that we're really excited about, we have, we're working with a second cohort of fourth-year nursing students at UBC Okanagan, and they're developing a recommendation for adding this topic to the curriculum for nursing students at UBC Okanagan. So we're hopeful that they will succeed, and then we can start pushing that request for curriculum addition across the country.
that's amazing.
Any other questions?
Well, thank you so much for having us.
Hearing none. If you do have any further questions, Dr. Paul and Karen both provided their contact information, and you can also reach them through me. October 15th, we're having grand rounds again, and it will be Dr. Lori Regenstreif speaking on methadone guidelines for prescribing in a fentanyl era. So sounds very interesting.
Thank you so much.
Thank you. Bye.
Pleasure. And
Have a nice weekend.
yes.
Yeah.
Thank